And you have two people.
Yes, so I just Ed and then the two people.
I just wanted to comment that in this discussion, there is the dichotomization of clinical care and research. And I think one of the things that's come up a number of times, it was in my comments, it was in Val's, I know this morning, and others, is that we really should be about informing every patient of what we're doing with them, what we know about what we're doing with them, what we don't know about what we're doing with them. We need to be honest with our patients. So I think this artificial dichotomization, it does concern me sometimes that if you're in a research study, I'll explain 90 pages worth of information to you, but don't expect information from me if I'm your clinician.
Around this question about waiver of consent and the question of could a study which randomly assigns people to alternatives within the standard of care, could the requirement for informed consent be waived or altered? My own personal opinion is yes, but the point I want to make is that the Federal Register raises that question and leaves it hanging. And I think the Federal Register notice that accompanies the draft guidance. So it would be important, I think, for us to ask for some clarification there. The Federal Register notice, the sort of third item, specifically raises the question, should an IRB be allowed to waive informed consent for research involving randomization of subjects to one or more standard of care interventions? In the discussion of comments, it says, one commenter expressed that there's nothing inherent in randomization that could preclude consideration of a waiver. But then in the response, which I assume represents the response from OHRP to this question, it's a bit vague. And even at this meeting, I've heard some people assume that response meant that waiver would not be allowed if we were randomly assigning to people who were sick to important clinical interventions within the standard of care, and others assuming it would be allowed. So to me, the lack of clarity there is very concerning.
Yeah. I just want to have a couple quick comments on this issue of minimal risk and waivers. And I guess, I don't know if Charles Vera is still here today, but I thought his component analysis he presented was very interesting because he was trying to suggest that we really ought to only apply minimal risk to those research interventions where there's not a therapeutic intent. And I think that's where we're getting to this issue of balancing risk and benefit of the therapeutic nature of things. However, the problem is the regulations require this determination of minimal risk. And I think we often have to gerrymander things into that in order to deal with the waiver when intuitively, as Rob was describing, we have a sense that it's not feasible without it. And my best example of that people have heard me talk about before is the Wisconsin Cystic Fibrosis Newborn Screening Trial, which I won't go into in detail, but simply to say that there must have been a waiver of consent done for that. I was not on the IRB at that time, but in fact, 650,000 newborns were screened for cystic fibrosis, looking at incidence of death and serious infections as part of this screening process. The point, though, was that whether or not it's called minimal risk or not, it's necessary to call it minimal risk in order to have the waiver. But the real issue is that was the issue of equipoise uncertainty. We had no idea whether this would be beneficial or harmful, and it was within the standard of care in that some states were doing CF newborn screening, some states weren't doing newborn screening, so Wisconsin decided to randomize people to try to address that question.
Tyson from Houston. Though the purpose of this workshop was not to include quality improvement activities, I think it's a central issue here because people will simply call something quality improvement in order to get a waiver. And there are, as Gord Guyot in that group has pointed out, there's no reason that quality improvement studies couldn't be randomized, that increases their validity, and that would be particularly true in the case of randomization to different usual care therapies. So I like the proposal that I've heard to avoid these arbitrary distinctions between care, research, and quality improvement activities and base it instead on the reasonably foreseeable risk to the patients, whatever you call it.
This falls into the same category as some of John Lantos's comments about how he'd remake the world if he could. But one of the things that we thought about and the University of Rochester presented in their comments at the time of the HHS meeting is that maybe when we think about some stuff that's comparative effectiveness research, we're trying to apply standards that don't quite fit, and that, as everybody has said, that the overall population risk, if you're in a comparative effectiveness research study, probably doesn't change from being in clinical care. The risk that accrues to individuals, or the harms or benefits that accrue to individuals, will change. But maybe that the overall, since the overall risk to the population doesn't change, it is reasonable to think about that change as being minimal from what would happen in the, I'll use the word haphazard application of clinical care. And that may be a way to think about whether or not it's reasonable in some very specific circumstances to waive or alter consent. In most cases, it probably wouldn't, because we respect people and we want them to know that their risks have changed. But since the overall risk to the population doesn't change, it may be times where it's completely infeasible to get consent, where we would find, if we asked the public, the patients, those questions, they might think that it was reasonable to waive or alter consent. And if that empirical evidence suggested it, then maybe we could move on, and John and I and whoever wants to join could remake the world.
And just a quick follow-up on that. I mean, altering consent seems much better to me in most cases than waiving consent. But altering consent, correct me if I'm wrong, people who know the regs, is impossible. Like
they have to be minimal
much
risk.
harder than waiving.
No,
it's the same.
the language
it's the same
is
requirement.
it's the same concept, because the language is waiving elements of consent. So that's the same as altering in some sense. But you're right, alter is not in the regs.
Whereas two-part consent for some of these studies with a brief oral consent or a brief disclosure that we want people to be in the study with an opt-in or an opt-out, and then some way to get more information later, seems like it would be preferable for many of these studies.
A sequential consent could certainly be approved.
I just think we have to be very careful about what we mean by risk and the language being used, and I think sometimes it's harms and outcomes are being conflated with risks. So the ex-ante evaluation of risk is just the product of the estimated probability and magnitude of harms. And as people have said, those will often be comparable, or will typically be comparable in this kind of research. So but people have talked about the distribution being different. The distribution of risk isn't different, though ex post, there may be people who are harmed as a result of of how they were assigned. But I think it's really important to say that doesn't mean that there was a difference in the risk distribution. The risk was the same. It's just that it may turn out after the fact that certain people were harmed as a result of the difference in what they were wound up being assigned. So I think we just have to be very careful about the language we use for talking about this.
And if you're going to be even more accurate ex post, it would be impossible to say whether someone who is harmed would not have been harmed had they not had the treatment they got.
Tom Obisha from Washington, D.C. Please allow me to thank the panelists for their thoughtfulness and openness with which we've been discussing this issue. My comment is going to be very brief. I want to make sure that the discussion is against the backdrop of the historical premise of human subject protection. I think if we constantly go back to that premise, I think some of these discussions will become a little bit clearer. With respect to risk, I think much of the discussion has focused on physical risk. We've not really talked about risk of breach of confidentiality, the possibility that if a drug does not work well or somebody is not responding to some category of medication, that this particular individual may have problem with insurance premium, may be unable to purchase long-term insurance, and so on and so forth. So when we talk about risk, we must think about risk in the context of all these dynamics, not just about physical risk. I also assume that individuals who are going to be enrolled in these studies are going to be monitored differently During this process, it is possible that you may uncover things that the individual may not want to know that may be traumatic to that individual, and that may affect their lives in ways that you've never imagined. I'd like to propose a slightly radical view. Perhaps we don't necessarily have to always randomize. There is something we can borrow from folks in Sweden. I'm sure many of you may be familiar with the MAMO study, where they follow people from conception, from birth until death. If you collect this kind of data clinically on millions of people, we are not talking about 1,000 people, 2,000 people, on 20 million people. You can slice that data any way you want. We know for a fact what constitutes variations in response, or what promote variations in response to drug therapy. We know a lot more now about genetic polymorphism. We know about the P450 system. I heard yesterday that someone saying that the era of personalized therapy is still far away. It's not. If you think about it, the genetic polymorphism with respect to coumadin is now being used, is almost becoming standard of care. We know a lot about pharmacokinetics and pharmacodynamics. We know about life factors that may modify. I think I'm going to cut you up a little bit, sir.
Yes,
I'm wrapping up.
Okay.
The point I'm trying to make is this. We can minimize risk and we can reduce the number of randomized studies in the way we know it. A lot of evidence can be gathered from this prospective kind of study. Thank you.
Thank you. Okay, I want to shift. I think all of the comments that have come up have really moved us in the direction of another question, which is, can standard of care be defined? We've had a number of presentations both here and yesterday. It seems like some of the questions are standard of care for whom, standard of care by whom, standard of care where, is it a cluster randomization, kind of standard of care. So what's important in terms of draft guidance is that the draft guidance has made an attempt to define standard of care. Can it be defined in a way that would appropriately be helpful for draft guidance that signals it out as something special to consider? Anne.
Well, it's hard to add to, you partially answered the question yourself, and I think we have answered I think people have answered the question probably for hours, that it is a usual care or a medical practice that might vary regionally by whom for a variety of circumstances and diversity. So to me, the fundamental issue is coming to grips with there is not the one standard of care, that it varies across the board, and having clarity of understanding that is going to be very important in addressing the draft guidance.
Yeah, I would follow up on that. I think one of the first presenters yesterday talked about just sometimes it's standard of care, sometimes it's standards of care. I think the guidance should define it rather than we as a community guessing what the guidance is telling us it is.
I guess Richard?
I think it's also important to avoid conflating the notion of practices in common use with practices about which reasonable people don't have strong preferences. So we have to sort of separate from the conversation the idea that both surgery and medical therapy are practices in common use for the same condition, and somehow think that that doesn't need a different kind of oversight than comparing two nominally equivalent medical treatments.
Are we going to be able to, not us necessarily, but is guidance going to be sufficiently able to distinguish, as people have raised, between standards of care and quality improvement research? And what are some of the issues that the OHRP guidance needs to consider to be actually useful to the research community, and not, as some people have suggested, kind of push the research community into calling more kinds of research quality improvement?
This is one of my hot button issues, and I'm glad you brought it up because we were told we couldn't discuss that today. but I'm glad.
Told me, I'm sorry.
It seems like so much of what we're discussing, we all know there's a continuum, and there's not a bright line, but yet describing it in some way that most people would agree on in general is still, from my point of view, a useful construct so that we can have discussions and compare among each other where we would draw the line given the uncertainties that exist. So in the Rich and Rob arguments, I've often argued that quality improvement is just poorly done research.
Wait, that's my line.
Yeah. But we also would agree that there are some things in quality improvement that are so sort of rudimentary that it wouldn't rise to the level of anyone necessarily.
Well, you
we'd
know
almost
what?
all agree.
I don't want to talk about defining quality improvement, because you're right, we should stay away from that. But I do want to talk about, can we define standards of care in a way that's different? Because some of the speakers have been talking about, well, this is what happens at institutions. So let's get back to the definition of standards of care in terms of how useful an OHRP definition can be to facilitate guidance in this area.
Well, I mean, I'm going to argue you can't get out of the box, even though you just tried to, because if you say A and B, where A and B are in common use, and let's just say if it's a drug approved by the FDA, or if it's which soap you use in a hospital, different hospitals are using different soaps and no one knows what's better, you have an option to either not learn while you implement or to learn while you implement. And if you choose to learn, you have an option of doing it well or doing it poorly. And so I think talking about coming up with some general notion of what usual care or standard of care is in a way that would help institutions deal with it is good. But then you're still going to have to get back to this thing about when you implement one version of it, how do you categorize it so you know who's overseeing it?
You're missing the key element of generalizable knowledge. You can do it well as long as you don't tell anybody about it, and it's still quality improvement.
Well, now you're really going to get me started. As long as we do secret human studies and don't tell anybody, that's okay.
Okay, I apologize for bringing it up.
I don't have an answer to the question is, can we define it? But I think we need to, not just in the context of, do we even need this guidance if we can't, but because there really aren't standards of care, and a lot of treatments are being used off-label, and access to those treatments is going to start being restricted based on that lack of knowledge. So I don't know who and how, but it needs to be done.
So for practical purposes, the definition of standards of care are whatever treatments enough doctors are using to be able to enroll enough patients to power a study.
Yeah. You know, I think our suggestion yesterday is that we should just stop using that term. It's not relevant to this issue. You know, part of why we use the term medical practices is just to describe these things that doctors do that we want to learn more about.
But that doesn't get us out of it either, Ben. How many doctors do it?
Well, no. But the issue is we're looking at the I don't know if we need to be that explicit. I think this is a category of research of medical practice for people who are requiring medical care as part of their usual day-to-day thing, which is different from the context of somebody who's in a clinical trial for an investigational drug that they may otherwise not. It may be optional as an approach. I think that what's key, as the context that Rich mentioned, is that this is embedded as part of usual practice. And as Rob said, this is going to be done on a large scale. It's these types of activities that we're talking about.
Okay, I think this just brings us to the question of that I think Len raised yesterday, and Marjorie was asking about as well as I. Is there something unique about standard of care research that requires additional guidance that is different from other RCT types of research? So let's think about that, and if so, why is it unique, and why does it need special guidance?
I think the reason we're having this discussion that relates to the last point is within things that doctors and hospitals and health systems do routinely there's a spectrum between we actually don't know anything about it, but we just do it, to we know a lot about it, but there are two alternatives. And I thought that one reason that we got into this is an argument was being made that if you knew a lot about the two alternatives and it was commonly known, then you could do the research with less oversight. That was the argument. What I've heard today is that everybody thinks, when possible, people ought to be informed about the risks and benefits. You end up with the same oversight, except in the case when it's not practical to do it, where then you get back into the box again.
John?
I think the difference is what the options are for people who don't want to be in a study. So in standard of care research or research on medical practice, if there's a study and you don't want to be in the study, you have access to either of the treatments that are being studied. If it's a study on an unapproved drug, the only way to get the unapproved drug is to be in the study. That's the big difference.
You know, there's a paradox I'm sitting here thinking about, which is that if you look at some of the definitions that are out there, including, I think, the one that's in the current proposed draft guidance, as to what constitutes the standard of care or a standard of care, at the top of everybody's list is those things that have been shown in well-done research to be effective and safe, or at least effective and have known risks. So maybe one way to think about standard of care research is all those things that are being done pretty routinely in clinical practice, for which there isn't very good evidence.
I guess the question becomes, does this type of research require unique regulatory interpretations? Because I think, as people mentioned yesterday, sometimes guidance born out of controversy is not necessarily as useful in retrospect, even though I think it's wonderful that OHRP is attempting to address it. And so from a regulatory perspective, is there something unique about this that requires a renewed emphasis on what is a reasonably foreseeable risk? A renewed emphasis on informed consent, a renewed emphasis on figuring out whether or not random assignment is or is not a risk. Valerie?
So my problem with all of this is that both the written regs and the discussion is relatively vague, and it's covering an unbelievable spectrum of research work that, you can't take phase 1, investigational trials in cancer or cardiovascular, you name the disease, and lump them together, in my mind, with QI projects that are looking at, Purell A versus Purell B. They're just not in the same continuum of risk to the patient, implications for the outcome, the level of evidence, and so on and so forth. So I guess I'm struggling with how the regs may be expanding ever so much, and whether or not there's some opportunity to place some degree of constraints around types of research, phase, trial, disease, investigational, that would get us in a better position.
In the way you frame the question, I would say research involving commonly used practices should require less stringent oversight regulation, informing and consent, not more. So you might say different, but in a different direction from what we're talking about. In the spirit of what Valerie was talking about, the rueful comment of some of our investigators are that that some of the institutional review boards they work with pay much more attention to what they consider to be very modest research interventions. Because they understand them, they can get their heads around them. Whereas you say, we want to do something terribly invasive, put in a probe into the central nervous system for a person who has a serious problem, they sort of back off because it requires a level of technical expertise that most IRBs don't have. And so there's this very sort of paradoxical higher level of scrutiny for lower levels of sort of risk.
Well, I'll just talk loud. Here, I'm on. Okay. So I think we need to differentiate between the obligation of both doctors, clinicians, and researchers, once they take on some responsibility for interacting with the lives of others, to speak to people about the nature of their disease, some of the implications for therapy and what the therapy might be where feasible. But that's apart from informed consent for trials. I think in terms of standard of care, we ought to probably break out studies that look at comparisons of, say, drug A, drug B, intervention A, intervention B, when there's equipoise about their use in quote unquote the usual sort of clinical, hospital, or everyday experience. In the case where there's drug A, B, C, D, E, F, and H, it's not clear that there's any standard of care. And I think that there it might be much more difficult to make an argument that there really that we know enough to call that standard of care research or discharge our obligations.
Wanted to bring up a point here, and it has to do with a lot of the discussion. It was brought up yesterday. I think we're missing voices in this discussion. We really need to have more of the patient advocacy group helping us to understand how they perceive this, because, you know, we're all consumers as well as practitioners, but we tend to be really influenced by our practitioners' hats. So I really think that, again, something to include in the comments regarding the guidance is that we really need to hear the voices of the patients, their families, and how they perceive these issues.
And I think that brings us to another question. We've kind of been addressing a number of the patient advocates who have spoken, have talked both about the need for added protections, but also the concern regarding barriers to research that they need. And so, once again, one of our charges is to think about the language in the guidance and the extent to which, how is this going to impact how IRBs are going to be evaluating research, and is it going to be added protections? Is it going to be barriers to the kind of research that's needed? And what suggestions might we make if there's going to be special guidance to kind of make sure that we're not creating barriers and we're also protecting our patients?
I mean, I worry that the guidance as written is going to create barriers. And not because the guidance is intended to create barriers. I think in the minds of OHRP it was meant to clarify most likely. But I'm worried that the response of a lot of IRBs, when all of the events going on right now are coupled with this guidance about randomization itself, whether we call it, we could have a long discussion about redistributing risk. I'm not sure I completely agree with some of the other comments here, but regardless, the guidance says if you randomize, people are passing up the opportunity to make their choice for the headache versus being randomly assigned to maybe getting the toe pain in a way they wouldn't have gotten had they had a choice. And so now you're into this thing of describing all the risks and benefits, having to get through minimal risks to get there, but the guidance almost leading some people to believe you can't get through the minimal risk gate because now you've got to describe risk. So I worry there could be a cascade that would be quite negative that would lead to barriers that patient groups would end up being very concerned about, because a lot of the most important, you know, we just did an 18,000 patient trial to find out that your LDL cholesterol actually does need to be lower than people thought. Now we need to compare different ways of getting there. If we have to go through the same thing, we spent over $500 million on one trial. Well, can't do that for a lot of things.
Andy?
So if I had to focus on two specific things that I would put on my wish list for this area, it would be to somehow lessen or broaden the ability to waive documentation of consent, because that's, at least in what little experience I've had looking in on some of these studies, that's what's really a big issue and problem. And then secondarily, also probably broadening the ability to waive consent entirely or alter consent significantly.
Yeah, John.
I mean, one of the things that I took away from this discussion and from yesterday is a sense both that research is changing in a way that makes old regulation less applicable, but also that we're getting a lot more research on what patient communities feel about what they want in terms of being enrolled in studies and getting the right information. So I wonder if a better recommendation would be to pick up on Jeremy's Hail Mary pass from yesterday and say, not necessarily to OHRP, but to the Secretary, that what we need now is not an attempt to set some guidance in stone. What we need now is permission to explore different ways of empowering people to understand what these new kinds of studies are about, to figure out what sort of information they want and what are the best means of getting it to them. So a more open-ended rather than constricted approach to looking at consent for these standard of care or research on medical practice studies over the next 5 or 10 years.
So since it's been opened up about consent, I just want to follow up on something that Robert said, and it's come up before. But we are tying ourselves to a 20th century technology in all the discussion about consents. We don't, people learn to the depth they wish to about whatever subject they're taking on at that moment in time. And it seems like we should begin to explore at least moving the consent process into the 21st century, where we can actually give people the option to being very superficial, if that's all they want to know, and digging as deep as they want to, should they wish to dig deeper. And I really think that we should comment on the need for a 21st century technology approach to informed consent.
In terms of reducing the barriers to research and the learning healthcare system, I really like what John Lantos proposed that would take a 5 or 10 minute conversation, he estimates, for most patients. A reality particularly important in my state, Texas, is that we get paid $35 for a 45-minute period of care for chronically ill children. And that's less than half of what the labor bill for repairs on my Toyota are. And to build into a system that's underfunded ways to promote learning and facilitate patient choice at the same time, I think John's proposal is really something that should be seriously considered that would address a lot of the concerns that were raised here.
Yesterday, when I was sitting up there, I suggested that perhaps the question of whether to adopt the OHRP guidance or not should be an empirical question, not simply a matter of ethical assertion. Well, the sports study might give us an example. The sports study, patients were either randomized to various surgical treatments or medical treatments for back pain, or they opted to go into an observational arm, which would be increasingly the option if we made it much harder for people to agree to be randomized. So if we could evaluate in a systematic way the conclusions reached if you ignored the randomized arm and looked at the observational arm, we'd have a better idea about the potential harms and maybe benefits of guidance that really did discourage people from being randomized.
Thank you. I have 2 points. The first is just a regulatory point. I'll try. There we go. The first is just a regulatory point. I think it's incorrect to say that these studies comparing drug A and B are not FDA regulated. I think they're exempt from the requirements for an IND, but I still think they fall under FDA regs, and so you're stuck with the lack of a waiver provision in the FDA regs. for the most part. And then the second point is that what struck me most yesterday really was that it was really the patient advocates that were voicing the strongest support for the idea of reducing the need for consent if it was going to be a barrier to this important research. And it kind of shocked me, and I guess I'm a little suspicious to some extent of that. Is this, what patient, or perhaps who are we really, who are the patient advocates advocating? Is this the population that has perhaps benefited the most from medical care because they've had exposure and benefited themselves from it? And what if we actually ask the population that has the least access to medical care, who really have the least potential of benefiting from this really important research, because they can't go to the doctor. Even with the Affordable Care Act, we have a huge population that lacks access. And I think, I'm curious, what is the voice of that potential patient population in terms of not being asked if they can participate in this research because it's too hard to ask to get it done?
So I'm going to make more formal comments during the public comment period, but I'm Sharon Terry. I'm the president and CEO of Genetic Alliance, which is a network of about 1,200 disease organizations. And I would say it's actually the inverse of what you just said, that those who do have a lot of care, I think, have probably what you would consider to be more typical expectations around consent. Those who have less access to care, and by that I mean both those without treatments and therapies because they're either in a subset of a population of a common condition, or they have a rare condition, or they're in an underserved community, are the people who are saying to us over and over and over, please, the risk of my condition, the harm that I already suffer is so enormous. We need to move this, and we need to move it now, so this should be metered out according to the risk I'm willing to accept. And there are some groups that have done actually great work in this area. Parent Project Muscular Dystrophy, for example, has actually worked with the FDA and talked about the risks they're willing to bear as a community because their boys will die. And death is certainly much more harmful than the risk of a research project. So I think what you've heard over the last 2 days is typical of what we hear, and I've been 19 years in this position from the disease communities.
I want to move to tinkering around the edges of the current system, which maybe left what we're doing, what we're left with doing, and that is one. You asked the question about, is there something that needs guidance? Well, maybe not guidance, but maybe some thought in comparative effectiveness research or standard of care research or ROMP, and that is that if we are studying things that are actually reasonably well understood, where the actual risks and benefits are reasonably well understood, that you might, the headache and toe pain example. One of the things that threatens to make consent more difficult or to add a level of complexity that doesn't need to be there is that the risks and benefits of drug A and drug B are really oftentimes the inverse of one another. So that you can imagine, and in a study that must not be named, this was one of the criticisms of the consent forms, you can imagine a consent form that says, if you take drug A, you have a higher risk of headache. If you take drug B, you have a higher risk of toe pain. And then in the benefits, you have if you take drug A, you have a lower risk of toe pain, and if you take drug B, you have a higher risk of the other thing, a lower risk of the other thing. That is almost ridiculous. And it might be reasonable to think about how that complex of risks and benefits, potential harms, potential benefits, could be laid out in a fashion that's a little bit more sensible in the circumstances where we actually know risks and benefits and where we're not comparing to a known comparator, which is the standard that's used for consent in what I'll call classic studies, where you're comparing new treatment to a comparator. Thanks.